Just yesterday, Dr. Redkamp and I talked about combination immunotherapy, and we just divided up the different combos and went through that. Combination immunotherapy makes a lot of sense because we're seeing some activity with PD-1, PD-L1 agents, but not enough that every patient's benefiting. In fact, still, I would say immunotherapy works great in 10% of patients, pretty well in another 10%, so 20%, but there's still 80% of patients that are going to be looking for something more, that are still going to be living with lung cancer and needing some more therapy. So I think that combinations are critical. The points I made in my talk were we need science-based combinations. We need to look and say, why is a patient resistant? Is it because they have the lack of PD-1, PD-L1, so use an agent that targets another checkpoint, LAG3, TIM3, or do they have PD-L1 but they just have myeloid-derived suppressor cells or T regulatory cells, macrophages that are inhibiting the process. So I think personalizing the therapy is going to help. I talked about agents that target the immune microenvironment, such as agents such as CD73, working on the adenosine pathway. I talked about agents that target macrophages, bispecific antibodies, oncolytic viruses, and several others. So there's a lot of energy in this field. There's a need for clinical trials, but clinical trials with biomarkers to really define who benefits and who doesn't, and to direct the right therapies to the right patient at the right time.